Okay, so chapter 30, under behavioral pain measures, look at the second paragraph down where it says the Flack pain assessment. Everyone see it?
Yes.
All right. So the Flack pain assessment tool is an interval scale that includes the 5 categories of behavior. You guys need to know what that Flack assessment tool is. What does it assess? Facial expression, leg movement, activity, cry, and consolability, which means if the baby's crying, are they easy to console to get them to stop crying, or no matter what you do, they keep crying? You need to know that, okay? It measures each behavior on a 0 to 10 scale with total scores ranging from 0, meaning no pain behaviors, to 10, the most possible pain behavior. The only behavior pain measurement tool recommended for use with children in critical care settings is the comfort scale. Make sure you know that. Now on the next page, page 765, look at table 30.1. Summary of selected behavioral pain assessment scales in young children. That Flack scale, again, you need to know it. There's a reason the author wrote about the Flack scale in text, and now you're seeing it again on the table. FLACC. Face, legs, activity, cry, and consolability. Now take a look over, same table, table 30.1, under number 2. Look what that means when it comes to the Flack scale. Frequent, constant frown, quivering chin. That quivering chin lets you know like they want to cry, they're about to cry. That's why that chin is quivering. That is significant. Everything, by the way, everything under number 2, that means worst pain possible. Anything higher than 4 is significant, but 10 is the worst, okay? For the legs, kicking, legs drawn up. For cry, they're crying steadily. For consolability, it's difficult to console or comfort them. So make sure that you know what the worst is and they fall under number 2. On page 765, right under table 30.1, self-report pain rating scales. In the first paragraph, just a couple lines down, it says self-report measures are most often used for children older than 4 years old. And that makes sense, guys. If they're older than 4 years old, they're big enough to tell you what hurts and where it hurts, right? We really don't have to use a behavioral scale, because if they're older than 4, they can talk, they can speak. Very next paragraph. It says Faces Scales provides a series of expressions depicting gradations of pain. Are they happy? Are they sad? The faces are appealing because children can simply point to the face that represents how they feel. So it's just a scale with different pictures of faces, and then the child can point to it to tell them how they feel. Are they feeling happy? Are they feeling sad? Do they want to cry? Go a couple lines down. Simple, concrete anchor words such as no hurt to biggest hurt are more appropriate than least sensation to worst intense pain imaginable. Remember, these are children, so they don't understand the word least or sensation, but they do understand the word hurt. Okay, so you can say hurt a lot or hurt a little. You want to use very concrete, simple words that they can understand. The ability to discriminate degrees of pain in facial expressions appears to be reasonably established by 3 years old. I'm going to the next page, page 766. I want you guys to look at that box 30.1, children's responses to pain at various ages. Everyone see that box? All right. For the young infant, they uses crying. That's how they communicate. Infant is birth to 1 year old. They can't talk and tell you what's wrong. They're going to cry. That's how they let you know that something's wrong. They reveal facial appearance of pain. You're going to see the brows lowered and drawn together and the eyes closed tightly. Under older infant, it says Uses crying. They'll still be crying. Remember, infant is still birth to 1. They're not talking yet. They're still going to let you know something's wrong by crying. They show a localized body response with deliberate withdrawal from what is causing the pain. So that older infant, that infant that's around 8, 9, 10, 11 months old, right? Even 12 months old, what they'll do is that body part that hurts, once they see you come near them, they'll withdraw. So pay attention to see what part of the body they're withdrawing, because that older infant can let you know what part of the body hurts simply by them withdrawing that part of the body, even though they can't verbalize it. They reveal expression of pain or anger. You can see on their face if they're upset with you, they want to punch you in the eye, right? God bless you. What about a young child? Young children, they can use words such as ouch, ow, it hurts. They'll attempt to push what is causing the pain away before it's applied. So look at this. When they were an infant, they would withdraw that part of the body that hurt. But the younger child, what can they do? They'll push you away. They'll slap that needle out of your hand, right? They'll display lack of cooperation and the need for physical restraint. So you got to give that kid a shot. They know it's going to hurt. They might try to slap that needle out of your hand, and the parents might have to restrain the child. They cling to the parent, nurse, or other significant person. For this reason, when I was a nursing student, I hated peds. I absolutely hated peds. I knew peds was the one arena of nursing I never wanted to go into, because as soon as I walked in the room, the kids hated me. I represented pain. And it didn't change until I became a nurse practitioner, and I get to order the injections, but I don't have to give them. So they have no problem with me. I leave the room, and whoever comes after me, that's who they have a problem with. They become restless and irritable with ongoing pain. They worry about anticipation of the actual painful procedure. So they haven't even had the procedure yet, but they understand that it's something painful and they worry about it. What about the school-age child? Look at what it says about the school-age child. They exhibit time-wasting behavior such as, wait a minute, I'm not ready. That's on NCLEX. Make sure you know that one. They give that one as an example so often when it comes to peds. They will do anything to prolong getting that shot or prolong that procedure. I got to go to the bathroom. Or wait 1 minute. And then you give them the minute, and then you're going to give them the injection. Wait, 1 more minute. They're going to do anything to try to prolong it. They'll display muscular rigidity. When they're scared, their whole body will clamp up, and you have to tell them to relax. Otherwise, that injection is going to hurt more. Examples: clenched fists, white knuckles, gritted teeth, body stiffness. What about the adolescent? Before I even get into the adolescent, one thing you guys have to know about the adolescent, just like the work of the child is play, that's how children learn about their environment. The work of the adolescent is self-identity. And the way that they find out who they are is from their social group. So socialization is a very big part for adolescents. It's very important for them. It's important. They want to be individuals, right? But at the same time, they don't want to stick out from their friends. They want to be just like their friends. It's complex. But when it comes to adolescent, they want to be seen as adults. So they may not necessarily want to show that they're scared or they're fearful, okay? They're less vocal with the physical resistance. Why? They want to be seen as grown-ups. They're more verbal in expressions such as, you're hurting me, get away. All right, take a look at table 30.2 where it says pain rating scales for children. This one also NCLEX asks about, make sure you know it, the Wong-Baker-Faces pain rating scale. It consists of 6 cartoon faces ranging from smiling face for no pain to tearful face for worse pain. And these are for the children that can't verbalize how they feel. All they have to do is point to the picture of what they're feeling, okay? Oh, one more thing important to know about the Wong-Baker Faces Pain Rating Scale. It's used for children as young as 3 years old. Because by 3, you can talk. All right, let's jump to page 769, where it says children with chronic illness and complex pain. Page 769, children with chronic illness and complex pain. Everyone there? Second paragraph down. Important components of assessment include the onset of pain. You have to ask, when did this pain start? The pain duration, how long did it last? The pain pattern, is this a type of pain that the patient's feeling? The effectiveness of the current treatment. Okay, whatever we're doing for this patient to relieve the pain isn't actually working, because guess what? If it's not, we're going to have to try something else. Factors that aggravate or relieve the pain. What makes the pain worse? What makes the pain better? Other symptoms and complications concurrently felt. Besides this pain that you're feeling right here, are you feeling it anywhere else? What does that feel like? And the difference in the child's mood, function, and interactions with the family. As a nurse, you gotta be watching that. Because let me tell you something. When it comes to pain, it is natural for children to express pain. Something hurts, they're gonna say ouch, they're gonna withdraw, they're gonna wince, they're gonna do something. If you see a kid going through a painful procedure and they stay stoic, their face, they're not flinching, they're not sad, they're not crying, alarm bells better be going off in your head, because one of the first things that better be going through your mind is possible abuse. That this child has learned that when they show pain, something bad happens, because it's not natural for them to experience pain and not have an outward manifestation or showing of that something hurts, okay? In addition to asking the child or parent when the pain started and how long the pain lasts, the nurse can assess variations and rhythms by asking whether the pain is better or worse at certain times of day or night. That can help give us a clue to see what is actually causing this pain, what's triggering it, what makes it better. If the child has had pain for a while, the child or parent may know which medications and doses are helpful. So when it comes to peds, guys, you have to get the parents involved. They're going to be the ones that's going to be supplying you with most of the information you need for the assessment. History. All right, let's look at non-pharmacological management. Same page, non-pharmacologic management. Pain is often associated with fear, anxiety, and stress. A number of non-pharmacologic techniques such as distraction, relaxation, guided imagery, and cutaneous stimulation can help with pain control. Something that's very important that helps relieve the anxiety, it helps relieve the fear, and in turn, that also helps relieve the pain, is explaining to them in very simple terms what you're doing and what they can expect. That alone will decrease their anxiety and anxiety of the parents, and that's going to help decrease some of the pain. Page 770. Nursing care guidelines, non-pharmacologic strategies for pain management. You see that big old, I don't know what we call it, table, chart, whatever that is. You guys see it? Non-pharmacologic strategies for pain management. Let's start with general strategies. Under general strategies, use non-pharmacologic interventions to supplement, not replace, pharmacologic intervention. So they're still going to get pain medication if needed, but in addition to that, we should be using non-pharmacologic approaches. Prepare the child before potentially painful procedures, but avoid planting the idea of pain. So you want to prepare them for something that may be painful, but don't put the idea in their head that they're going to have pain. How can we do that? Look at this. For example, instead of saying, this is going to hurt, say, sometimes this feels like pushing, sticking, or pinching. You want to use non-pain descriptors, such as it feels like heat, instead of saying it's a burning pain. You see the difference? Avoid evaluative statements or descriptions. Don't say things like, this is a terrible procedure, or it really hurts a lot. Can you imagine what that does to a kid when you say that to a kid? And remember, children, they have magical thinking. We're going to get into that in a little bit. Stay with the child during a painful procedure. Hold their hand. Allow parents to stay with the child if the child and parent desire. Encourage parents to talk softly to the child and remain near the child's head. If it's something such as injection and it's a small child, allow the small child to sit on that parent's lap. It's going to make a world of a difference. Involve parents in learning specific non-pharmacologic strategies and in assisting the child with their use. Educate the child about pain, especially when explanation may lessen the anxiety, and explanations do lessen the anxiety and fear. For long-term pain control, offer the child a doll, which represents the patient, and allow the child to do everything to the doll that is done to him or her. Remember, play is the work of the child. That's how they work through their emotions. That's how they learn about their environment, through play. So you can give them a doll, or you can give them crayons and paper and let them draw out, the different procedures. And through that, they'll express their feelings. Under specific strategies, everyone see specific strategies? Involve the parent and child in identifying strong distractors. What is that child really into? They really, really, really love Barney. Let's play some Barney while they have to get this painful procedure. Involve the child in play. Have the child take a deep breath and blow it out until told to stop. That's a wonderful distractor. Did you do your third assignment? Good girl. Have the child blow bubbles to blow away the hurt. They have imaginative, magical thinking at this time. So they really don't think that as they're blowing the bubbles, they're blowing that hurt away. And psychologically, they'll feel like that pain has become less, or it's even gone away. Relaxation, use relaxation techniques. What do we do with an infant or a young child? With an infant or young child, hold them in a comfortable position. You may rock them. You may repeat nice, kind words softly. You teach a mom to do that, such as "Mommy's here." With a slightly older child, you can ask them to take a deep breath and go limp as a rag doll. You can teach them relaxation techniques. Let's jump all the way down to behavioral contracting. Everyone see behavioral contracting? Before I get into behavioral contracting, something you guys have to understand, this behavioral contract that you have, it must be agreed ahead of time. If you try to incorporate, where's my coffee? If you try to incorporate the behavioral contracting during the time when the kid's acting up, that's not behavioral contracting, that's bribing. And we don't bribe as nurses, right? So it's very important that we do this ahead of time. We have the agreement ahead of time. So behavioral contracting. Informally, it can be used with children as young as 4 to 5 years old. And it gives you different examples, such as giving stars, tokens, things like that. Make sure you guys take a look at the list. And formally, you can use a written contract. That would be for an older child, and they give you examples, realistic goal or desired behavior, such as a realistic goal is them not trying to swat the needle out of your hand, right? But we expect them to cry, that's okay, but we don't want them to act a fool to the point that the parents have to restrain them. That's a realistic goal. Identify rewards and consequences that are reinforcing. But again, we do this when? Ahead of time. Agree before time. All right, let's go to page 771, Pharmacologic Management. Pharmacologic Management, everyone there? For children older than 3 months old with mild pain, the first step, the first thing you do, remember guys, I told you when you're studying and you ever see them list something in order, they tell you that the very first thing that you should do or your priority That's important. Pay attention. The first step is to administer a non-opioid, such as an NSAID. And you give that for mild pain. A strong opioid is usually administered to children with moderate to severe pain. Okay? When it comes to moderate or severe pain, the drug of choice is what? Morphine. Very good. Morphine is the medicine of choice for the second step, although other opioids may be considered. So we're first going to try a non-opioid such as an NSAID. And then if that patient has moderate to severe pain, then we're going to try an opioid such as morphine. Okay, let's talk about non-opioids. Non-opioids, next paragraph. Non-opioids, including acetaminophen, which is Tylenol or paracetamol, that's what they use in Europe, and NSAIDs are suitable for mild to moderate pain. Non-opioids are usually the first analgesic for pain related to tissue injury, also known as nociceptive pain. Let's talk about opioids. One thing to say about opioids, moderate to severe pain. Remember, when it comes to opioids, moderate to severe pain. Okay? Next page. Page 772, table 30.3. NSAIDs for children, everyone see that? Put a star next to acetaminophen, Tylenol. The first one, it says acetaminophen, Tylenol. Put a star next to it. You guys need to know it. And I did farm with you, so you know I'm not big on the dosages, but when you need to know those dosages, I let you know. Yes, acetaminophen is one of those. You have to know the dosages. Table 30.3. Acetaminophen, Tylenol. You must know the dosage. So the dosage is everything okay back there? Guys, listen, whatever I don't go over with you, you're still going to be responsible for. So I can go over these 2 chapters with you, but whatever I can't cover, you're still going to be responsible for, okay? All right. So the dosage for acetaminophen, you guys absolutely need to know this. 10 to 15 milligrams per kilogram per dose. Not per day, per dose, which means every time you give it. Per dose, every 4 to 6 hours by mouth, not to exceed 5 doses in 24 hours, or 75 milligrams per kilogram per day, or 4,000 milligrams per day. I know you guys love when I skip pages, right? Page 777, under PCA, patient-controlled analgesia. Everyone there, patient-controlled analgesia. I can't pronounce analgesia and I give up. You guys see it. That's what I'm talking about, PCA. Page 777 towards the bottom. What, about 5 lines down. Sorry about this, guys. Next week, I should have the camera back up so you can follow along. Children who are physically able to push a button, 5 to 6 years old, and who can understand the concept of pushing a button to obtain pain relief can use a PCA. Now, on NCLEX, when you get a question about a PCA, most often, they're trying to draw a couple things out of you. Either one, do you understand that in order to have a PCA, you have to be cognitively able. So you have to at least be around 5 or older, right? Because children younger, they really won't understand, okay, I feel pain, push that button. Some do, but we won't trust them to do it. That's number 1. Number 2, again, cognitively inclined. So if it's a child that has cognitive deficits, it's not a good idea to give a PCA, right? Because they have to be cognitively competent, yes?
So the PCA is determined not by like a specific age.
Well, we go by certain ages. They're 5 or older, but in addition to that, they have to not have cognitive deficits. Okay? And then the third thing, you have to teach the parents. The only person who should be pressing this button is the patient. Because if they're old enough and they've been deemed cognitively competent, they know when they have pain. Because what happens is that child will be sleeping and they may grunt in their sleep, and the parent's afraid and they think the kid has pain and they press the button. But guess what? If that pain was so bad, the kid would have woken up to press the button themselves. So you have to teach that to the parents. Something else you have to teach to the parents is they're not going to overdose, because there's a set amount that is prescribed with that PCA. And there's a certain not duration, frequency that is set. So if they're only allowed to get 5 milligrams every 4 hours, and it hasn't been 4 hours, they can press that button as much as they want. They will not get that 5 milligrams. Okay, so those are some very important things to know about the PCA. So when they do, NCLEX ask about the PCA, they ask about those 4 or 5 things. Just make sure you know that. Page 779, box 30.4. where it says side effects of opioids. Highlight, put a star next to constipation. That is very important. It can cause constipation to the point that that patient now has obstruction, paralytic ileus. We got to be careful, because you mess around and have decreased blood flow to that GI tract, right? You got necrosis in part of that tract. You got fecal matter building up. God forbid you get a tear. So that's very important. What else? Respiratory depression. You better highlight and put a star next to that. Patients on opioids, you better be checking their respirations and make sure it's between 12 and 20. It's not dropping less than 12. And sedation. Think safety. Now, you guys need to know all the rest, but those are the 3 most important that need to be going to the back of your mind once you think of opioids for the kids, okay? Next page, page 780, that box that says managing opioid-induced respiratory depression. Everyone see it? If respirations are depressed, remember, respirations are supposed to be 12 to 20. If they're depressed, which means they drop to less than 12, assess their sedation level. How awake, how alert are they? Reduce infusion by 25% when possible. By the way, let me give this to you in order. The first thing you're going to do is assess their sedation level, right? Next, this is the second thing you're going to do, is decrease infusion by 25% when possible. The third thing you're going to do, stimulate them. Shake their shoulders gently. Call them by name. Ask them to breathe. Give them oxygen. That may usually be enough to kind of bring those respirations up. Something they did not put on here, but I'm going to add, and this is a common theme on NCLEX, so you guys need to know this. When it comes to lungs, when it comes to respirations, patients, the respirations are decreased, patient has trouble breathing, you always want to sit them up. You always want to increase the head of the bed. And the reason for that is you got to think about those lungs, or the diaphragm that's sitting right here under the lungs, right? You take a deep breath, the diaphragm drops to let air in, and then as soon as you breathe out, it's supposed to pop back up. Well, the lower that patient's lying down, the abdominal girth is pushing up against that diaphragm, against the lungs. They're not going to be able to expand the way that you want it to. So you're always going to elevate the head of the bed. Make sure you add that on there. Yes, ma'am.
For children, where is the respiration normally about? Where is it still at 20?
What are we still doing? We're doing children, so it's 12 to 20.
Okay.
It's higher when we get to the really, really young ones, like the infants. Speaking of infants, here we are. Chapter 31, the infant and the family. So chapter 30, we were talking about pain, but pain for everyone, for children. But now we're talking specifically about the infant, birth to 12 months. Once they're 12 months, they're 1 year old, they turn into a toddler. So we're talking about infancy. Let's take a 5-minute break and then come back so we can do infancy. Sure.
Yeah. I don't like it because last time this was like half the month.
Okay, guys, chapter 31, the infant and the family, page 790. Everyone there? Under proportional changes. Remember, we're talking about the infant. So we're birth to 12 months. Under proportional changes. Infants gain 150 to 210 grams weekly until they're about 5 to 6 months old, which is when birth weight has at least doubled. That is important. At 6 months, we expect to see the weight double. An average weight for a 6-month-old is 7.3 kilograms, about 16 pounds. By 1 year old, the infant's birth weight has tripled for an average weight of 9.75 kilograms, about 21.5 pounds. Make sure you know, by 6 months, their weight doubles, and by 1 year, it triples. Don't say I didn't warn you. Next, what do we call this column?
Yes.
Next column. Closure of the cranial sutures occur with the posterior fontanelle. You guys need to know this. The posterior fontanelle closes by 6 to 8 weeks. The anterior fontanelle closes by 12 to 18 months. You need to know when the anterior and posterior fontanelle closes. Page 31.1, growth and development during infancy. For the 1-month-old. Under vocalization, you need to know, they cry to express displeasure because remember, they can't speak. And under socialization and cognition, the 1-month-old is in the sensory motor phase, stage 1. For the 2-month-old, the posterior fontanelle closed. Under fine motor, that grasp reflex starts to fade. Under sensory, they can turn their head to the side when a sound is made at the level of the ear. So when they hear something close enough to their ear, they'll turn their head. Under socialization and cognition for the 2-month-old, the social smile in response to various stimuli. Because the smile before now was just reflexive. But now their smile is social. They're actually happy about whatever it is they're smiling about, okay? At 2 months old. 3 months old. At 3 months old, their primitive reflexes start to fade. Under fine motor, the grasp reflex is absent. Remember, at 2 months, it started to go away, but by 3 months, the grasp reflex is absent. Under vocalization, they'll start to coo, babble, even chuckle. Under socialization and cognition, they can recognize familiar faces and objects, such as the feeding bottle. They see the bottle and then they smile. 4 months old. Moreau, tonic neck, and rooting reflexes have disappeared. We're going to learn what all of those are, but for now, just know that they've disappeared at 4 months old. Under socialization and cognition, they anticipate feeding when they see the bottle or the mother is breastfeeding. They associate mom with food, or they associate that bottle with food. So if they see that bottle, then maybe someone rang the doorbell and mom walks away with the bottle, they're going to start crying because they're expecting that bottle to go into their mouth. 5 months old. This is the beginning signs of tooth eruption. And remember, around 5, 6 months of, by 6 months, their weight should have doubled. By 6 months. But, you know, around 5 months old, their birth weight doubles, but they have up to 6 months. For gross motor for the 5-month-old, they can turn over from abdomen to back. Under fine motor skills, they're able to grasp objects voluntarily. It's not a reflex. They actually wanted whatever it was that they grasped. Under socialization and cognition, the 5-month-old smiles at self in the mirror. At that age, they love looking at their reflection in the mirror, and that's how they're learning about themselves. They'll smile and move their head from side to side. What's that? They're conceited. They're able to discriminate strangers from family. So this is the beginning of stranger anxiety, because now they know, who's familiar to them. They discover parts of their body. At 6 months old, he may begin with eruption of 2 lower central incisors. You need to know that. At 6 months old, they're able to roll from back to abdomen. Under vocalization, they begin to imitate sounds. So, since birth, you've been saying mama, mama. They might start saying ma. Socialization and cognition. They briefly search for a dropped object. This is known as object permanence, but this is the beginning of object permanence, where they start to understand even if something's out of sight, it's still there. This is the beginning. They don't have a concrete understanding yet, but it's the beginning, because you drop an object and they'll still look for it, which means they understand that it may possibly still be there. Okay. So 6 months old, that is the beginning of object permanence. 7 months old, eruption of the upper central incisors. Under gross motor, they can spontaneously lift their head off of the surface. They can sit leaning forward on both hands. They can bear full weight on their feet. Under sensory, they can fixate on very small objects and focus on it. Socialization and cognition for the 7-month-old. They have an increasing fear of strangers. They start to show signs of fretfulness when the parent disappears. That parent, they come to understand that parent is their safety blanket, their safety net. 7 months old, they start to like peekaboo. I don't know why NCLEX loves peekaboo, but they love asking about peekaboo. Make sure you know peekaboo. At 8 months old, under gross motor, they sit steadily unsupported, and they may stand holding onto furniture. Socialization, they start responding to the word no. Now, let me make this clear. Responding to the word no doesn't mean they stop what they're doing, but they may be doing something wrong, and mommy or daddy says no. They'll stop for 1 second, look at them like, who are you talking to? And go back to what they're doing. But the fact that they stop for that 1 second lets us know that they understand what that word no means. Or they may hear that word no and start to cry. So they respond in some way to the word no, but don't think the word no, that they'll just stop doing what they were supposed to stop doing. That's not the case. 9 months old. You guys are going to be doing lots of index cards because you better know these. 9 months old. Eruption of the upper lateral incisors may begin. Under gross motor, they can pull themselves to standing position and stand holding onto furniture. For fine motor, they use their thumb and index finger in crude pincer grasp. You've seen the 9 months old where they grab everything like this? You give them a little Cheerio and they take it like this. At 9 months, preference for use of dominant hand is now evident. You can tell if they're going to be left-handed or right-handed because they prefer to do things with a certain hand. Under vocalization, the 9-year-old comprehends no. 10 months old, under vocalization, they start to say dada, mama with meaning. Because before they were just repeating what they heard, but now They're saying it with meaning. They see their mom and they say mama. They see their dad, they say dada. They comprehend goodbye. They hear mom or dad saying bye-bye. They start crying because they know their parents are going to leave. They understand bye-bye. They may say one word such as hi, bye, no. Socialization and cognition for the 10-month-old. They develop object permanence. You take a toy, put it behind the couch, they'll go crawl behind the couch to look for it. That's very important. Make sure you know at 10 months old, they develop object permanence. They like to play interactive games such as patty cake, where they're patting your thigh, you're patting the hand, you're rolling the hand. They like those types of interactive games. Or the, this little piggy went to market and, you wiggle the little piggy, their little toe, yes, or finger. 11 months old. At 11 months old, we have eruption of the lower lateral incisors that may begin. They cruise or walk holding onto furniture or with both hands held. Socialization and cognition of the 11-month-old. They anticipate body gestures when the familiar nursery rhyme or story is being told. So when you're doing this little piggy went to market, they're anticipating when you're going to go grab that big toe. They play games up, down, so big, or peekaboo. They start to shake their head for no. You tell them to do something, they go like this to you. They tell you no. At 12 months old, birth weight has tripled. Remember, it doubles by 6 months, triples by 12 months. Birth weight's tripled. The Babinski reflex has disappeared. We'll be talking about that reflex. Gross motor, they can walk with one hand being held. They attempt to stand alone momentarily, but they'll fall. And they may attempt their first step. Fine motor skills, they'll attempt to build 2-block tower, but fail. Vocalization. At 12 months, they say 3 to 5 words besides mama dada. They understand simple verbal commands such as give it to me or show me your eyes. Under socialization, they're fearful of strange situations, so they'll cling to the parent. They search for an object even if it has been hidden, but searches only where the object was last seen. That's known as what? Object permanence. Thank you. Very good. On page 795, the same page we're on, go 3 paragraphs down where it says maternally derived iron stores. This is important for you guys to know. Maternally derived iron stores are present for the first 5 to 6 months of life. So those iron stores that this infant has for the first 5 to 6 months of life, they got it from mom, right? Maternally derived iron stores are present for the first 5 to 6 months of life and gradually diminish, which also accounts for the lowered hemoglobin levels towards the end of the 6 months. Page 796, 3 paragraphs down, where you see thermoregulation. During infancy, thermoregulation becomes more efficient. This ability of the skin to contract and of muscles to shiver in response to cold. So that's how they warm themselves. Shivering, thermogenesis, causes the muscles and muscle fibers to contract, generating metabolic heat, which is distributed throughout the body. Increased adipose tissue, that's the fatty tissue, increased adipose tissue during the first 6 months insulates the body against heat loss. We call it baby fat, right? Next column, binocularity, or the fixation of 2 ocular images into one cerebral picture. That's called fusion. This begins to develop by 6 weeks old and should be established by 4 months old. Let's talk about fine motor development. Fine motor behavior includes the use of hands and fingers in the prehension, that's the grasp of objects. Grasping occurs during the first 2 to 3 months as a what? As a reflex. They're not doing it on purpose. As a reflex and gradually becomes voluntary. That's why it's important for you guys to know when it becomes voluntary, because before then it was a reflex. Next paragraph. By 6 months old, infants have increased manipulative skills. They hold their bottles, they grasp their feet and pull them to their mouths and feed themselves crackers. They can do a lot by 6 months. By 7 months old, they, and this is important, guys, they transfer objects from one hand to another. By 7 months old, they transfer objects from one hand to another, use one hand for grasping, and hold a cube in each hand simultaneously. They enjoy banging objects and exploring movable parts of toys. We need to make sure that those toys are so large that they can't put it in their mouths. So we don't want any choking hazards. So, 6, 7 month old, is it a good idea to give them marbles to play with? No. Okay. Gradually, the palmar grasp, that's using the whole hand, is replaced by the pincer grasp using thumb and index finger by 8 to 9 months old. And that's why it's called fine motor skills, because at first it's very crude. They're going to use their whole hand. They don't have that dexterity yet to do this. So they're doing this. Okay? By 10 months old, they've progressed to a neat pincer grasp sufficient to pick up raisins and other finger foods. By 1 year old, this is the last sentence of that paragraph. By 1 year old, infants try to build towers of 2 blocks, but they what? They fail. They try, but they fail. All right, let's go to gross motor development. We're going to talk about head control. Full-term newborns. Full-term newborns can momentarily hold their heads in midline and parallel when their bodies are suspended ventrally, and can lift their head and turn their heads from side to side when they're prone on their stomach. This is not the case when infants are lying prone on a pillow or soft surface. Let me stop right there. Why are they telling us this? They're telling us this because this is a risk for suffocation. You put them prone and you put them on the pillow, they're going to suffocate because they cannot lift their head to breathe. Okay? Infants do not have the head control to lift their heads out of a depression of an object, and therefore risk suffocation in the prone position in early infancy. So in early infancy, what you're going to do is called tummy time. You don't want to have them on their back 24 hours a day because you're going to make them have a flat head, right? We don't want to deal with that. So we give them tummy time. We're going to put them prone, but we're going to put them prone when they're awake, number one, right? We don't want them sleeping because their head's going to be down. Remember, they can't lift their heads. And number two, when we're watching them. You don't ever put that child prone and turn your back, even for a second. Couple lines down. By 4 months old, infants can lift their heads and front position of their chest approximately 90 degrees above the table, bearing weight on their forearms. By 4 to 6 months of age, head control is well established. Next column, rolling over. The ability to willfully turn from the abdomen to the back occurs around 5 months of age, and the ability to turn from back to the abdomen occurs around 6 months of age. Guys, notice we saw this information in the table a couple pages ago, and now we're seeing it in text. You think this is going to be on your exam? You better believe it. It's important to place the infant in a supine position for sleep. We don't want them to suffocate. When infants are awake, a prone position, that's what's known as a tummy time, is acceptable to enhance achievement of milestones, such as head control, learning head control, crawling, creeping, turning over. Okay, I put some notes on the side because I couldn't find it in the book, but NCLEX asked you about it, so I need to make sure you know it. What did I write here? Oh, okay, I see what I wrote. Any, any head lag after 6 months of age needs a development assessment. They need to be checked. They need a neurological assessment. Okay. If they are 6 months age or older and they've got head lag, they can't lift their head, there's a problem. We have to ask for a neuro assessment. And also, what did I write? I wrote tummy time, smiley face, only while awake. I told you guys that already. And then I wrote never side or prone. So when they're asleep, here's the thing, in real life, you'll see on the U-board floor, a lot of the nurses, when the baby's sleeping, they'll put the baby to sleep on the side. Let me tell you something. You put them on their back. You do not put them prone. You do not put them on the side. You put them supine. That is very important. The baby sleeping, they're what? Supine. Think of back to sleep, on their back to go to sleep. And be careful, because I know you guys are going to be doing clinicals. When you guys are testing, don't try to recall what you saw on the nursing floor when you were doing clinicals, because remember, clinicals in real life, we care about money, we care about time, we care about resources, we care about staffing, we care about equipment, but when you're testing, it's a perfect world, you have all of those. So please make sure you go buy the textbook. I can't stress that enough. Page 798. Sitting. The ability to sit follows progressive head control and straightening of the back. Locomotion. About halfway through that paragraph of locomotion, it says by 6 to 7 months old, they're able to bear all of their weight on their legs with help, with assistance. Crawling, that's propelling forward with the belly on the floor, progresses to creeping on the hands and knees. That's the belly off the floor by 9 months of age. At this time, they stand while holding onto furniture and can pull themselves up to a standing position, but they're unable to maneuver back down except by falling. By 11 months old, they walk while holding onto furniture or with both hands held. And by 1 year old, they may be able to walk with one hand held. Look at the nursing alert. An infant who does not pull to a standing position by 11 to 12 months old should be further evaluated for possible developmental dysplasia of the hip. All right, let's move on to Erickson's psychosocial development, developing a sense of trust. That is the stage of the infant when it comes to Erickson, trust versus mistrust. That child, that infant either learns to trust the environment, trust the caregiver, trust that their needs will be taken care of, or they'll develop a distrust of their environment, distrust of the caretaker, distrust that their needs will be taken care of. Erickson's phase, you must know that the theorist, which is Erickson, and you must know the phase of the infancy. Erickson phase, which is birth to 1 year old, is concerned with acquiring a sense of trust while overcoming a sense of mistrust. Infancy, Erickson, trust versus mistrust. The trust that develops is a trust of self, of others, and of the world. Infants trust that their feeding, comfort, stimulation, and caring needs will be met. I'm going a couple lines down. The provision of food, warmth, and shelter by itself is inadequate for the development of a strong sense of self. So just feeding them and changing them is not enough for them to have a strong sense of trust. They need also what? Affection, right? Next paragraph. Failure to learn delayed gratification leads to mistrust. Mistrust can result either too much or too little frustration. If the parents always meet the child's needs before the children signal their readiness, infants will never learn to test their ability to control the environment. If the delay is prolonged, you wait too long, the infant will experience constant frustration and eventually mistrust others in efforts to satisfy them. Therefore, what's essential, guys? Consistency. Consistency is essential. There has to be a balance. You don't want to always anticipate their needs and not allow them to, and in the infant stage, you're going to cry and not allow them to cry to express their needs for their needs to be met. But at the same time, you don't want to wait too long to meet their needs. Okay, so there has to be a balance. You have to have a balance and you have to be consistent. By the way, when it comes to peds, in all pediatrics, I'm talking about up to the older adolescent before they become an adult, they all strive on consistency. As much as they try to act like they hate having rules and they hate having structure, they thrive off of structure. Structure is very important in pediatrics. All right, page 799. Cognitive development, sensory-motor. So this theorist is Piaget. The period from birth to 24 months. Okay, we're talking about Piaget. With Piaget, Piaget was more concerned with cognition, how the child thinks. Page 800. During the sensory motor phase, remember when it comes to sensory motor, the theorist is Piaget, the age is birth to 24 months. During the sensory motor phase, infants progress from reflexive behaviors to simple repetitive acts to imitate activity. 3 crucial events take place during this phase. You need to know those events, guys. The first event involves separation, in which the infants learn to separate themselves from other objects in the environment. The second major accomplishment when it comes to sensory motor is the concept of object permanence. Put a star next to object permanence. Object permanence, the realization that objects that leave the visual field still exist. The third and last major accomplishment is the ability to use symbols, and that's known as mental representation, such as that bottle representing food. Page 801, under development of body image. Second paragraph down. Achieving the concept of object permanence is basic to the development of self-image. By the end of the first year, infants recognize that they are distinct from their parents. Because before then, in their mind, it's just them and their parent were one. Now they're able to distinguish themselves from the parent. At the same time, they have increasing interest in their image, especially what? The mirror. Pay attention, guys, because a lot of this information is repetitive. And the same information that you see is repetitive, that's the information you're going to see on the test I give you. That's the information you're going to see on the ATI. That's the information you're going to see on NCLEX. They're not repeating the information just for the heck of it. By the way, this last information I gave you about the mirror, that's been seen on NCLEX very often. Make sure you know that. Page 802. Next page, under social development. That last paragraph under social development, play. Play is a major socializing agent, and it provides stimulation needed to learn from and interact with the environment. That is the work of the child. That's how they learn, by play. By 6 months old, infants are very personable. They play games such as what? Peekaboo. When their heads are hidden in the towel, they signal their desire to be picked up by extending their arms, and they show displeasure when a toy is removed or their faces are washed. They hate getting their faces washed. I don't know why. Attachment. Go to the second column, second paragraph down. When infants are not provided a safe haven and consistent and loving care, an insecure attachment develops. Such infants do not feel they can trust the world in which they live. This insecure attachment may result in psychosocial difficulties as the child grows and may persist even into adulthood. Insecure attachment can also exist in homes where there's domestic violence and maternal postnatal depression. Because if mom has postpartum depression, she's not really meeting that child's needs the way she should, right? And so absolutely that child may develop a mistrust of the environment, of the world, of the caretaker. Next paragraph. Attachment progresses during infancy with the infant assuming an increasingly significant role in the family. Two components of cognitive development are required for this attachment to occur. One, the ability to discriminate the mother from other individuals. And the reason for that, guys, usually the mother is the primary caretaker. But obviously, if the baby's in the home where it's only the dad, just put the dad in there. Two, achievement of object permanence. How important is object permanence in peds? Very, right? All right, let's go down to the next paragraph. For the first few weeks of life, infants respond indiscriminately to anyone because the first few weeks of life, they can't even tell the difference. Okay, so they respond indiscriminately to anyone. Beginning at about 8 to 12 weeks old, they cry, smile, and vocalize more to the mother than to anyone else, but they continue to respond to others, whether familiar or not. But mom is special. At approximately 6 months of age, infants show a distinct preference to the mother. They follow her more, cry when she leaves, enjoys playing with her more, and feels most secure in her arms. About 1 month after showing attachment to the mother, many infants begin attaching to other members of the family, most often the father. Sorry, dads, you have to wait the whole month after. Infants acquire other developmental behaviors that influence the attachment process. This includes, make sure you guys read that on your own. I'm not going to go over them, but make sure you know them. Couple lines down, there are two different patterns of attachment disorder: the emotionally withdrawn pattern and the indiscriminate disinhibited pattern. A couple lines down from that. Infants at risk for severe attachment disorder include, and you have to know this, guys, those who have been victims of physical or sexual abuse or neglect, infants exposed to parental alcoholism, mental illness, substance abuse, and infants who have experienced the absence of a consistent, underline that word consistent, a consistent primary caregiver as a result of foster care or institutionalization, parental abandonment, parental incarceration, whatever the case is, they didn't get that consistency from the parent that they needed. Children with RAD, that's something attachment disorder. What does the R stand for? Reactive, okay. Children with reactive attachment disorder may manifest such behaviors such as not being cuddly with parents, failing to seek and respond comfort to when distressed, minimal social and emotional reciprocity. You're smiling or the parents are smiling with them and they're not returning that. Emotional deregulation such as unexplained fearfulness or irritability. Children with DSED, that's social engagement disorder, they exhibit behaviors such as inappropriate approach to unfamiliar adults. You don't know this adult, but you're sitting on their lap. You see that, one of the first things you need to be thinking about is sexual abuse. Lack of suspicion of strangers, poor impulse control. 2 lines down, and this is on NCLEX, you need to know this. I keep saying this is on NCLEX. I'm sorry, guys. I do not write NCLEX. Let me make this clear. This has been seen on NCLEX. You need to know this. Without early intervention, some of these children fail to develop a conscience and develop antisocial personality disorder that may lead to criminal acts. You're going to learn more about this when you get to psych. Separation anxiety. We see this around 4 to 8 months. Between 4 to 8 months old, infants progress through the first stage of separation individual, and they begin to have some awareness of themselves and their mothers as separate beings. Object permanence is developing, and infants are aware that their parents can be absent. About 5 or 6 lines down. By 11 to 12 months of age, they're able to anticipate her immediate departure. Look at this, by watching her behaviors. By 11 to 12 months of age, they understand if mom picks up her purse or her keys, or they see her looking for her shoes, okay? They begin to protest before she leaves. The minute they see mommy looking for her shoes, they start crying. Or they see mom picking up her purse. Mom hasn't even walked to the door yet, but they understand. At this point, many parents learn to postpone alerting the child to their departure until just before leaving. They'll put the keys right next to the door. They'll put the shoes right next to the door. They'll put their purse right next to the door to not cause anxiety in the child until they're right about ready to leave. Stranger fear. Between 6 and 8 months old, fear of strangers and stranger anxiety becomes prominent and is related to the infant's ability to discriminate between familiar and unfamiliar people. Language development. Infants' first means of verbal communication is what? Crying. That is their first means of communication before they learn to speak. Next paragraph. Crying tends to decrease by 12 weeks old. Couple lines down. At the end of the first year, infants cry for attention. They cry from fear, especially from strangers, and from frustration, usually in response to their developing but inadequate motor skills. So they may see something colorful because they love colorful objects and they want to grab it, but they're unable to. And so they'll cry out of frustration. 7 or 8 lines down. By 9 to 10 months old, they comprehend the meaning of the word no and obey simple commands, even if it's for a second. By 1 year old, they can say 3 to 5 words. Make sure you guys know that by 1, they can say 3 to 5 words with meaning, and they may understand as many as 100 words. Couple lines down. It's important that infants are exposed to expressive speech and that infants with delays in achieving milestones are carefully evaluated for potential hearing loss. So it's very important you're going to teach the parents that even though it's an infant, they can't read, it's important to read to them and speak around them. They need to hear that expressive speech. They need to hear those words because remember, before they start to speak words, they imitate them, right? And so they'll try to imitate the words that they hear before they say those words with meaning. All right, play. Second paragraph of play. Play is dependent. Pleasure is demonstrated by a quieting attitude, 1 month old, a smile at 2 months old, or a squeal at 3 months old. That's how you know they're happy. From 3 to 6 months old, infants show more discriminate interest in stimuli and begin to play alone or with rattles or soft stuffed toys or with someone else. By the way, it's not enough just to give the child a toy to play with. They need that human interaction, okay? By 4 months old, they laugh aloud. They show preference for certain toys, and they become excited when food or a favorite object is brought to them. They recognize images in the mirror, they smile at them, and vocalize to them. Put a star next to this, what I'm about to say. By 6 months to 1 year old, play involves sensory motor skills. Games such as peekaboo and patty cake are played, and they enjoy it. At 6 to 8 months old, they usually refuse to play with strangers because now they can tell family from strangers. Parents are definite favorites, and infants know how to attract their attention. Next paragraph. Stimulation is as important for psychosocial growth as food is for physical growth. It's not sufficient to place a mobile over crib and toys in a play yard for a child's optimal social, intellectual, emotional development. It's not enough. They need that human interaction. Now, don't get me wrong. A mobile is a great toy for an infant because while they're in the crib on their back, sometimes they're looking up. And the thing with the mobile It's colorful. They love the color, so that stimulates them visually, right? And it's turning, so they can watch it turn, and it makes music, so it's stimulating them with the sound. So a mobile is a wonderful toy for an infant, but that's not enough. Play must provide, excuse me, interpersonal contact and recreational and educational stimulation. Infants need to be played with, not merely allowed to play. Page 804, under coping with concerns related to normal growth and development. Let's talk about separation and stranger fear. Towards the end of that very first paragraph. To accustom the infant to new people, parents are encouraged to have close friends or relatives visit often, because when they see those family members come often, they won't really view the family members as strangers anymore. This provides other persons with whom the child's comfortable and give parents time for themselves. Those parents will never be able to take a break if the only person the child is not fearful of is the parent. So they're going to need babysitters. They need the child to be comfortable with trusted family members. So you have those trusted family members visit often, so the child does not view them as strangers anymore. Because that stranger anxiety, that is a defense mechanism, and that's a healthy defense mechanism. Okay, we're not trying to get rid of that, but we need the people who can love and take care of that child while you're gone. That child be accustomed to them. Infants also need opportunities to safely experience strangers. You can't have them in a bubble, but they have to be safe at the same time. Usually towards the end of the first year, infants begin to venture away from the parent and demonstrate curiosity about strangers. If allowed to explore at their own rate, many infants eventually warm up, but it can't be forced, okay? If parents hold the child away from their face, the infant can observe while maintaining close contact to the parent. So they can observe the stranger and fulfill that curiosity, decrease that anxiety, while at the same time, please still being comforted knowing that the parent is right there with them. Notice the set away from the face. What I'm about to say next, put a star next to. This has been seen on NCLEX. Make sure you know it. The best approach for a stranger, including nurses, is to talk softly. Meet the child at eye level. Why? You want to appear smaller. When you're standing up and you're addressing the child, you look like a giant. So you want to get down at their eye level to address them. So you're not as scary. Guys, I'm so sorry. We're going to go a little bit over time. Forgive me. You want to avoid sudden intrusive gestures such as holding out the arms and smiling broadly. They don't know you. Next paragraph, parents need to be reassured that such behavior is healthy, it's desirable, and necessary for the child's optimal emotional development. If parents can reassure the infant of their presence, the infant will learn to realize that they're still there even though not physically present. Talking to infants when leaving the room. So you have somebody watching the infant, because remember, you never leave an infant by themselves. But let's say you have your sister watching the infant, but you leave the room and go to the kitchen, but you're still talking to the infant so they can still hear your voice. Allowing them to hear one's voice on the telephone, using transitional objects such as a favorite blanket or toy, reassures continued presence of the parent. Next page. First column towards the bottom is the last paragraph where it says one area that's increasing. Everyone see that? Page 805. One area that's increasingly important in selecting childcare is the center's health practices. However, parents often don't check the center for health and safety features. Evidence shows that children, especially those that are younger than 6 years old in daycare settings, have more illnesses. And guys, that makes sense. You know, kids are nasty. You know, they love sharing their germs. What are those illnesses we see the most of? Diarrhea, otitis media, those are ear infection, respiratory tract infection, such as cold, especially if the caregiver smokes, because when they smoke, you can smell that smoke on their clothes. Hepatitis A, meningitis, cytomegalovirus. We see that more in children who are in daycare than children who stay home. The strongest predictor for the risk of illness is the number of unrelated children in the room. So the biggest predictor of the illness in children is how many children are in that classroom that the child's going to be in. Next column, limit setting and discipline. Give me 10 more minutes, okay, guys? Under limit setting and discipline, about 5 or 6 lines down, an effective approach used in disciplining a child is a use of timeout. And here's the thing about timeout. You're going to do the timeout for the age of the child. So for example, if they misbehave and they're 2 years old, you're going to put them in timeout for 2 minutes. And the reason for that, longer than 2 minutes, they forgot why they were in timeout. So it's like you're punishing them, but they don't even know what they did wrong. Remember, they're very small, so their attention span is very limited. You don't want to punish them for a reason that they don't even know why they're being punished, okay? For example, a play yard is better for most infants than in a chair. Although parents may be concerned about instituting discipline during infancy, it is important to stress, look at this, guys, the earlier effective disciplinary measures are used, the easier it is to continue these approaches. Last column under limit setting and discipline. It must be reiterated continually that infants cry because a need is not being met, not to annoy you. You have to tell the parents that. You have to remind them they're crying because there's a need that's not being met. They're not crying to be annoying. A fussy or irritable infant is a potential victim of shaken baby syndrome or other bodily harm because adults and caretakers may not understand the nature of the infant's crying, so they may just get frustrated and shake the baby. So it's very important to teach it with the patient. Thumb sucking and use of pacifier. Sucking is infant's chief pleasure and may not be satisfied by breastfeeding or bottle feeding. Next paragraph. Problems arise when parents are overly concerned about the sucking of the fingers, thumb, pacifier, and they attempt to restrain the child from doing that. Sucking is how the child self-comforts. It's normal. It's healthy. Before giving advice, nurses should investigate the parent's feelings and base guidance on this information. You always want to assess first, ask questions. Okay, what about the sucking is bothersome to you? What are your concerns? Page 806, about 4 lines down. The American Academy of Pediatric Task Force on Sudden Infant Death Syndrome cites strong evidence for protective effect in SIDS reduction when pacifiers are used at bedtime and nap time. The exact mechanism involved in the protection for SIDS is not known, but still, pacifiers should be cleaned and replaced regularly, and there should be an emphasis on allowing the infant to control the pace, frequency, and termination of feeding rather than to allow the pacifier or anything else to become the focus of the interaction. Pacifier use during painful procedures in neonates has been shown to produce an analgesic effect. It calms them down. Last paragraph on the same column. During infancy and early childhood, look at this, there is no need to restrain non-nutritive sucking of the fingers. If they want to suck their fingers, let them. There's no need to restrain them from that. We're almost done. Teething. Everyone under teething? The first primary teeth to erupt are the lower central incisors. Ooh, we saw that in the table. We're seeing that again. These appear at approximately 6 to 10 months old. A quick guide to assessment of the deciduous teeth during the first 2 years is the age of the child in months minus 6. And that's a quick guide to remember. And that'll tell you the number of teeth you expect them to have. For example, if they're 8 months old, 8 months minus 6, you expect them to have 2 teeth. Okay? Next paragraph down, maybe about 9 or 10 lines down. Because teething pain is a result of inflammation, cold is soothing. So when they're teething, it might be painful for them. You could suggest a teething ring that's been placed in the freezer or the refrigerator because it's cold. Giving the child a frozen teething ring helps to relieve the inflammation. Look at this, but do not freeze the teething rings filled with gels or non-sterile water because they might crack. Remember, they just got teeth. They might bite it, and now that gel that was inside the teething ring, the child can ingest it. Okay? Last paragraph. The use of teething powders or procedures such as cutting or rubbing the gums with salicylate, that's aspirin, is discouraged because ingestion of the powder, infection or irritation of the tissue, and ingestion or aspiration of aspirin can occur. Do we ever give kids aspirin? No, there are very few instances that we give aspirin. You know, something like Kawasaki, we'll get into that later. But 99.9% of the time, we do not give children aspirin because of the risk of Ray's syndrome. Hard candy can cause accidental choking or aspiration and should be avoided at this age. Take a look. This is the last thing I'm going to say to you guys. Take a look at figure 31.10. Make sure you know that. At what age you expect to see what teeth erupt. Okay? Make sure you guys go over the rest of chapter 31. Any questions?